this lecture, we will be discussing the electrophysiology of the heart. This includes the following concepts: the cardiac action potential, cardiac automaticity, ECG waveforms, and the electrical vectors. Now, you may notice that some of these concepts have been discussed previously, and in that case, we will only rehearse those concepts briefly. Let's start by viewing the cardiac conduction system, or the electrical conduction system of the heart. This image displays the cardiac conduction system, or the components of the conduction system. As you remember, the electrical conduction system is basically the electrical cords which spread the cardiac impulse rapidly to the entire myocardium. The electrical conduction system starts with the sinoatrial node, which is the heart's intrinsic pacemaker. That is, during normal circumstances, the heart has its own pacemaker, which is the sinoatrial node. And this is explained by the fact that the cells in the sinoatrial node are capable of spontaneously and repeatedly discharging action potentials. And every action potential is an electrical impulse, which will spread through the heart in the direction shown by these arrows. This is the spread of the impulse in the atria, and when the impulse arrives to the AV node, it will be delayed slightly because impulse conduction through the AV node is slow, and then it will continue in the bundle of His, which is branched into the right bundle branch, and the left bundle branch, which again is branched into the posterior fascicle and the anterior fascicle. Now, from the fascicles and the bundle branches, the Purkinje fibers spread out into the myocardium. And you may remember that the Purkinje fibers, they run in the endocardium, which is the myocardial layer closest to the cavity of the ventricles. This is the ventricular cavity, and the muscle layer lying here is the endocardium. This is where the Purkinje fibers run. And the same thing in the left ventricle. This is the endocardial layer of the left ventricle and where the Purkinje fibers run. And you should also know by now that the Purkinje fibers, they deliver the electrical impulse to the contractile cells in the ventricles so that they can contract. Let's repeat that. The cardiac cycle begins in the sinoatrial node. The cells in the sinoatrial node, they discharge an electrical impulse or an action potential, which will spread through the right atrium initially and then to the left atrium. And then the impulse will arrive at the AV node, where it will be delayed slightly because of slow impulse transmission through the AV node. And then the impulse will continue through the bundle of His, the right bundle branch, the left bundle branch, the anterior and the posterior fascicle. And from the bundle branches and the fascicles, the impulse will continue through the Purkinje fibers, which will then deliver the impulse to the contractile cells in the endocardium of the ventricles. Now, the Purkinje fibers are not connected with all of the contractile myocardium. The Purkinje fibers are only connected to a portion of the contractile cells in the endocardium. However, the electrical impulse will spread to all the remaining contractile cells as well, because the myocardial cells, that is the contractile cells, they are also connected to each other. You may also remember that the depolarization, that is the activation of the atria, is reflected as a P wave on the ECG curve. This is the P wave. So the P wave reflects atrial activation or atrial depolarization, which is the same as atrial contraction. The QRS complex, which is this complex depicted in orange, this reflects the depolarization of the ventricles. Again, depolarization is the same as activation or contraction. So the Q, R, and S waves, they reflect the ventricular contraction or ventricular activation. Then finally comes the T wave. And the T wave reflects the repolarization or the recovery of the ventricular myocardium. So let's repeat that. The P wave is atrial activation. The QRS complex is ventricular activation. And the T wave is ventricular recovery. Now that means that we cannot see the atrial recovery on the ECG. And that is simply because atrial recovery would occur somewhere between this point and this point, which means that atrial recovery will occur simultaneously with ventricular activation. And because ventricular activation generates much stronger electrical potentials, they will dominate this phase in the cardiac cycle, which is why we are only seeing the QRS complex and we cannot see the atrial recovery. Before we leave this image, you should be familiar with the electrical conduction system. You should know that the electrical conduction system serves as the electrical cords of the heart, and the normal ECG waveforms are represented by a P wave, which is atrial activation, a QRS complex, which is ventricular activation, and a T wave, which is ventricular recovery. You should also note that activation of atria or ventricles is the same as depolarization, and this causes contraction of the myocardium. You should also know that repolarization is the same as recovery of the myocardium. This image shows the myocardial syncytium. And the myocardial syncytium is simply the architecture of the myocardial tissue. On this image, the yellow cells are the conduction cells and the red cells are the contractile cells. As mentioned previously, the conduction cells primarily spread the cardiac impulse through the heart. These cells do not contract, they just spread the impulse rapidly to the contractile cells, which are the red cells. And then the contractile cells will contract as soon as they receive the electrical impulse. As you can see, all of the cells in the heart are connected to each other through gap junctions. And these gap junctions are just tunnels between the cells. And these tunnels are made up of protein complexes, which allow for ions to move from one cell to the next, so that the electrical impulse can spread from one cell to the next. It also means that the conduction cells, they are only connected with the minority of all the cells in the heart. But that's not a problem, because the electrical impulse can spread from contractile cells to contractile cells via these gap junctions. Now there is a fundamental difference between conduction cells and contractile cells. The first one is obvious. The contractile cells are good at contracting, whereas the conduction cells contract very little or nothing at all. On the other hand, the conduction cells are capable of transmitting or conducting the electrical impulse very fast. The contractile cells, on the other hand, only allow for slow conduction of the electrical impulse. That means that the electrical impulse will travel very fast through the conduction cells. But as soon as the conduction cells have delivered the impulse to the contractile cells, the remaining conduction of the electrical impulse will be slow. So impulse conduction between these cells is slow, and impulse conduction between these cells is very rapid. Now, in the previous lecture we also discussed the cardiac transmembrane potential. And this is a key concept in electrocardiology. This purple box represents a myocardial cell. This is the cell's interior and this is the cell's exterior. These boxes, the orange one, the two gray ones, the blue one and the pink one, they represent proteins which are embedded into the cell membrane. And these proteins are used to maintain very specific concentrations of ions in the cell's interior and the cell's exterior. Because these proteins, they work actively around the clock to pump positive ions out of the cell so that the concentration of positive ions is greater outside the cell as compared with the inside of the cell. And this means that there will actually be an electrical gradient across the cell membrane, because the concentration of positive ions outside the cell will be greater than the concentration of positive ions within the cell. And this difference in positivity will cause a voltage gradient across the cell membrane. And this voltage gradient will function as a battery. And this battery is used to start intracellular signaling, which ultimately leads to contraction of the cell. This is done by suddenly allowing ions to move into the cell. And once they do so, the ions will affect several of the intracellular proteins, and this will ultimately cause the contractile proteins to become activated. And when the contractile proteins become activated, the cell starts to contract. This process is called activation or depolarization. The reason why it is called depolarization is simply because the cell is no longer polarized after this process. That is, it becomes depolarized. Nevertheless, in order for the cell to be able to contract again, it must repolarize, which basically means that the battery must be recharged. And this is done by moving the positive ions out of the cell again. So the action potential is simply the depolarization and the repolarization. And that means the activation and the recovery. This diagram shows how the cardiac action potential is presented. This is just an ordinary diagram with voltage on the y-axis and time on the x-axis. As you can see, there are basically 4 phases. This is the resting phase of the action potential. During this phase, the cell is inactive. And this is the depolarization, and it reflects the activation of the cell. This phase is referred to as the initial repolarization, and after that comes the plateau phase, and finally the rapid repolarization. Note that during the resting phase, the membrane potential is negative at minus 90 millivolts. And this is simply because the cell's interior is less positive than the cell's exterior. That is, there are more positive ions outside the cell as compared with the inside. But when the cell is stimulated, that is, when the cell becomes depolarized, positive ions flow into the cell so that the cell membrane or the membrane potential becomes less negative. You should also note that the repolarization of the cardiac cell is done in 3 steps. It starts with the initial repolarization, which is an incomplete process because it only repolarizes the membrane potential slightly. And then comes the plateau phase, during which the membrane potential is virtually unchanged. The final and complete repolarization occurs during this phase, which is the rapid repolarization. After the rapid repolarization has been completed, the cell can be stimulated again. Now, in the previous lecture, we also discussed the refractory periods, and there are two refractory periods during the action potential. There's an absolute refractory period and a relative refractory period. So what you need to know about this is very simple. During the cardiac action potential, the cell is absolutely refractory from the beginning of the depolarization to the beginning of the rapid repolarization. And this means that during this phase, the cell cannot be stimulated again, which basically means that the cell cannot trigger another action potential during this period. But this part of the cardiac action potential is the relative refractory period. And during this period, the cell can actually trigger another action potential if it is stimulated by a strong stimulus. So during the relative refractory period, the cell may be stimulated again and trigger another action potential if the stimulation is strong. But during the absolute refractory period, the cell cannot be stimulated again regardless of the intensity of the stimulus. And on the ECG curve, the absolute refractory period starts with the QRS complex and it ends approximately on the apex of the T wave. The apex of the T wave corresponds to the relative refractory period, and this means that you will sometimes see extra beats or additional beats occurring on the T wave. Now let's take a look at how that would appear on the ECG. This is a normal beat. This is also a normal beat. But you see that this T wave is interrupted by an abnormal beat. This beat is abnormal because it appears to be much wider than the normal beat, and the direction of the QRS complex is opposite to the STT complex, and it occurs much too early in the cardiac cycle. So this is an abnormal beat, and it occurred on the T wave. This may be referred to as an R on T phenomenon. And this beat is referred to as a premature ventricular complex, or a premature ventricular beat, or extrasystole. There are many names to refer to these beats. Now the reason why R on T phenomenon are of interest is simply because the apex of the T wave is a sensitive phase in the cardiac cycle. And to be frank, it's not always sensitive, but it may sometimes be sensitive in some patients. And as a general rule, any patient which has an electrical instability in the ventricles, such as patients with acute myocardial infarction or acute myocardial ischemia, or perhaps long QT syndrome, or any other condition in which there is an electrical instability in the ventricles, these patients may be sensitive to R on T phenomenon. And in the worst case scenario, an R on T phenomenon may actually cause a ventricular fibrillation and ultimately a cardiac arrest. And that would look like this. We have an R on T phenomenon which causes a ventricular fibrillation. Now this is also an interesting image, and the only purpose of this image is simply to show you that the cardiac action potential, or the appearance of the cardiac action potential, differs in the different cell types of the heart. This action potential is the action potential which can be recorded in the sinoatrial node. As you can see, the appearance of this action potential differs from the green action potential, which represents atrial myocardium, which again differs from the pink action potential, which is the cells in the AV node. Now let's get into some details regarding the cardiac action potential. And as I mentioned in the previous image, the action potential differs in the different cells of the heart. And we will primarily focus this discussion on the cells of the sinoatrial node and the contractile myocardium. And this image tries to illustrate the sinoatrial node as this structure. And as you can see, the cells in the sinoatrial node are connected with the contractile myocardial cells, which are depicted in red. And the action potential will start in the sinoatrial node when these cells depolarize. And as you can see, the action potential will propagate or spread from the sinoatrial node to all the surrounding cells. And this is possible because all the cells in the heart are connected via gap junctions. Now we have already discussed the different phases of the contractile cells, or the contractile myocardium. We did mention that the first phase is referred to as the resting phase, and this may actually be numbered as phase 4. And then phase 0 is the depolarization. Now I know the numbering of these phases don't make much sense, but it doesn't matter. This is how it's decided. So phase 0 is the depolarization, phase 1 is the initial repolarization, phase 2 is the plateau phase, and phase 3 is the rapid repolarization. Now I also want to mention a few things about the movement of ions during these phases. Now during the resting phase, there is a constant but small outflow of potassium. That means that potassium moves out of the cell during the resting phase. And this is what causes the resting membrane potential to be negative, because the positive ions are moved out of the cell. During the depolarization, there is a rapid inflow of sodium. That is, sodium will move quickly into the cell. And this is what causes the cell membrane to be less negative. During the initial repolarization, potassium will again move out of the cell, so that the cell membrane becomes more negative again. Then there's a plateau phase, during which the membrane potential is virtually unchanged. And during the plateau phase, there is a constant inflow of calcium to the cell. And this inflow of calcium will sort of counterbalance the outflow of potassium. And then during the rapid repolarization, there's again an outflow of potassium. Now you might ask yourself, do I really need to know this? I mean, these are quite detailed concepts regarding the movement of ions, and the answer is very simple. You do not need to know this for clinical purposes. The only thing which is important about this is that you understand the concept. That is, the action potential consists of a depolarization and a repolarization, and during these phases there are movement of ions into and out of the cell. That's all you need to know. But there is one more thing which you should know about the action potential, and that is simply the appearance of the action potential in the cells of the sinoatrial node. And this image shows the appearance of the action potential in the sinoatrial node. Now, the major difference between the action potential in this cell and this cell is simply that the cells of the sinoatrial node do not display any resting membrane potential. If you look here, the cell becomes depolarized in the same way that the contractile cell becomes depolarized. And then the cell will repolarize. But as soon as the cell has repolarized, it will actually start to depolarize again slowly. And this is called a pacemaker potential. And this pacemaker potential is explained by the fact that as soon as the cells have repolarized, they will immediately start to leak sodium into the cell. And this continuous leak of sodium into the cell will cause the cell membrane to become more and more positive until the cell membrane reaches a level of approximately minus 40 millivolts. And once the cell membrane reaches a level of approximately minus 40 millivolts, then the depolarization will be triggered, because this membrane potential is the threshold for triggering the action potential. So this basically means that once the cells in the sinoatrial node have depolarized and repolarized, they immediately begin to leak sodium into the cell. And sodium will leak into the cell slowly and steadily, so that the membrane potential becomes less and less negative until it reaches the threshold. And once that has been reached, the cell will depolarize because it will be triggered to do so. And this cycle repeats itself over and over again. And this is what explains the automaticity of the cells in the sinoatrial node. This is simply an image depicting where there are structures in the heart which possess automaticity. And automaticity is simply the ability to depolarize spontaneously without any prior stimulation. That is, cells which possess automaticity, they are capable of depolarizing spontaneously. And these cells, they function as pacemakers because they can depolarize repeatedly and spontaneously, so they can discharge action potentials which spread through the heart and activate the heart. You're probably familiar with the sinoatrial node, which is the primary pacemaker structure of the heart. Now, the sinoatrial node has an intrinsic rate of spontaneous depolarization, and that is 70 depolarizations per minute. This means that during normal circumstances, the cells in the sinoatrial node, they depolarize spontaneously 70 times per minute. And this would lead to a heart rate of 70 beats per minute. Now, the reason why the heart rate is not always 70 beats per minute is simply because the sinoatrial node is influenced by the parasympathetic and the sympathetic nervous system, which decreases, respectively increases the heart rate. And this is done by affecting the automaticity in the sinoatrial node. So the heart rate may increase when the automaticity in the sinoatrial node is increased. And the opposite is also true. Heart rate will decrease when the automaticity in the sinoatrial node is decreased. As you can see on this image, there are other structures in the heart which are also capable of spontaneously discharging action potentials. And these structures have been discussed in the previous lecture. You should go back to that lecture if you've forgotten these structures. Now let's summarize what we have learned so far. We have discussed the myocardial cells, which are also referred to as contractile cells. We have discussed the architecture of the myocardial tissue, which is referred as to the myocardial syncytium. We've discussed the conduction cells and the various components of the conduction system. We've also looked at the ECG waves, particularly the P wave, the QRS complex, and the T wave. We have discussed the transmembrane potential as well as the action potential. We have also discussed the pacemaker potential and automaticity. And these 6 are all the basic or the fundamental concepts of electrocardiology. You need to be familiar with these concepts in order to understand ECG interpretation. So now that we have rehearsed all of these concepts, we have one more important topic to discuss, and that is the electrical vectors of the heart. And the whole concept about vectors is also fundamental to ECG interpretation. This image shows how the electrical impulse spreads from the sinoatrial node to the atria. These small arrows represent the direction of the electrical impulse. So these arrows actually represent the direction of the smaller electrical currents. And you can see that some of the currents are directed downwards. These ones head a bit more to the right on the image, and these are directed more horizontally to the right. Now, if we would consider the average or the main direction of all these smaller currents, we would obtain the electrical vector. That is, the electrical vector represents the average direction of all the small currents in any given moment during the cardiac cycle. So this arrow actually shows the average direction of all the small currents during this phase in the cardiac cycle. It's very important to understand this concept, so let's repeat it once again. In any given moment during the cardiac cycle, the electrical vector is the average direction of all the electrical currents which spread through the myocardium. So this is the average direction of the activation during this phase in the cardiac cycle. Now, the reason why vectors are so important is because they relate to the understanding of the ECG leads and the ECG waveforms. Consider this image. This is a simplified image which shows the heart, two electrodes, the ECG machine, that is the electrocardiograph, and there is one ECG diagram. Now this diagram is actually the ECG curve, or even more correctly, the ECG lead. So this ECG lead is obtained by using or analyzing two electrodes. These electrodes will generate the ECG curve by analyzing the electrical vectors which exist during the cardiac cycle. And the electrocardiograph, that is the ECG machine, has a very simple construction. One of the electrodes is programmed as positive, and the other is the negative electrode. And the ECG machine is programmed such that if an electrical current travels towards the positive electrode, it will generate a positive wave on the ECG curve. Again, this lead is obtained by using two electrodes. One of the electrode is positive and the other one is negative. If the electrical vector travels towards the positive, it will yield a positive wave on the ECG curve. And the opposite is also true. If the electrical vector travels away from the positive electrode, which you can see here, it will yield a negative wave on the ECG curve. Now I want to add a few more notes. First of all, the positive electrode is often referred to as the exploring electrode, and the negative electrode is typically referred to as the reference. Now, in many ECG books and discussions elsewhere, it is often stated that in any ECG lead, the heart is observed from the angle of the exploring electrode. So, for example, in this lead, the heart would be viewed from its left aspect. That is, the heart would be viewed from this angle. But in reality, both electrodes actually view the heart, but it's only when the vector travels towards the positive electrode that they generate a positive wave. And to make things easier to understand, we often say that the heart is viewed from the positive electrode because all of us can remember that the ECG curve will show positive waves when vectors travel towards the positive electrode, and the waves will be negative when vectors travel away from the positive electrode. So this is the classical ECG curve, and what you are seeing here is actually the result of the electrical vectors which exist during the cardiac cycle. And we did mention in the beginning of this lecture that the P wave corresponds to atrial depolarization, the QRS complex corresponds to ventricular depolarization, and the T wave reflects the ventricular repolarization. So from this image, I could guess that atrial depolarization consists of one electrical vector, because I can only see one wave on this ECG curve. And the QRS complex appears to consist of three vectors, because there are three waves. The ventricular repolarization appears to consist of one vector. Now let's take a closer look at each of these vectors and how they are generated. This is a quite busy image, but we'll go through it step by step. This is the heart, and this is the anterior wall of the chest. So the chest has been cut in the horizontal plane. This is the right atrium, this is the left atrium, the right ventricle, and the left ventricle. This is the interventricular septum. On the chest wall, we have attached two electrodes. Each of these electrodes will be compared with the same reference, and this reference is actually located here, behind the heart, within the chest. Now you may wonder how it is possible to have a reference within the chest, because we do not place any electrodes there. And we will discuss this in detail in the next lecture. But for now, you only have to know that this reference is located within the chest, behind the heart, and it is obtained by taking the average of the electrodes placed on the right arm, the left arm, and the left leg. Because when we take the average of the electricity which is detected by the electrode on the right arm, the left arm, and the left leg, when we take the average, we will end up with a reference point located in the middle of the chest. And that is this point. This point is referred to as Wilson's central terminal. And we will discuss this in detail later. So for now you only have to know two things. The electrodes which are placed on the chest wall, they are exploring electrodes, and they are compared with a reference located within the chest, and this reference is actually composed of more than one electrode. So this means that the reference is not necessarily a single electrode. It may be composed of the average of two or three electrodes. However, the exploring electrode is always a single electrode. Okay, let's move on. This is the reference, and this electrode is the exploring electrode. And it is actually the exploring electrode in lead V1, which you may have encountered earlier. And this is the exploring electrode in lead V5, which you may also have encountered before. So these two leads are actually standard ECG leads which occur every day in clinical practice. V1 is obtained by comparing the electrical currents detected here with the electrical currents detected here. And V5 is obtained by comparing the electrical currents detected here with the electrical currents detected here. Now let's analyze these vectors. The very first vector which arises during the cardiac cycle is this one, the atrial vector. And the atrial vector is generated by activation of the atria. As you can see, this vector is actually composed of two vectors. One generated by the right atrium and the other one generated by the left atrium. When the right atrium is activated, the vector is directed as shown by this arrow, that is anteriorly and to the left. Then the depolarization or the activation will continue to the left, whereby the electrical current will turn a bit to the left. And note that the entire heart is actually rotated counterclockwise in the chest, so that the left atrium is actually located somewhat to the back. And this explains why this vector is actually directed somewhat posteriorly, that is, towards the back. So, let's look at lead V1. When lead V1 analyzes these vectors, it will detect that initially this vector will travel towards V1, which is why V1 displays a positive wave, which is this wave, the P wave. However, the activation of the left atrium will be directed away from lead V1, which is why V1 often, but not always, shows a negative deflection in its terminal portion. That's right. The P wave in V1 may actually be biphasic, as you can see here. That is, the initial portion is positive, but the terminal portion may be negative. And this is not always the case, but it's quite common finding, and it is explained by the fact that the vector generated by left atrial activation is directed away from V1. Let's go to V5. V5 will only detect vectors traveling towards it throughout the atrial activation. And therefore V5 will display positive P wave. There is no negative deflection in V5 because there is no vector heading away from V5. Now you may note that the vectors are not traveling directly towards V5, but V5 will still yield a positive wave. The next thing is the activation of the ventricles. Activation of the ventricles starts in the interventricular septum. Because septum obtains Purkinje fibers from the left bundle branch, the activation of the septum will start where the left bundle branch runs through the septum, and that is in its leftmost portions. So the interventricular septum will be activated in its left portions initially, and from there the depolarization will spread to its right portions. So the vector will be directed as shown by this arrow. That is, the vector will be directed anteriorly and to the right. So lead V1 will detect a vector traveling towards it. And this vector is actually small, and that is explained by the fact that the interventricular septum consists of a rather small muscle mass. V5, on the other hand, will display a negative wave. And you should note, in V5, this wave is defined as a Q wave because it is negative. But in lead V1, the same electrical vector yields a positive wave, which is defined as an R wave. So the R wave in V1 and the Q wave in V5 are actually generated by the same electrical current, but that current is being viewed from two opposite angles. Next is the activation of the free ventricular walls, which are these walls. Now, because the right ventricle is much smaller than the left ventricle, this phase in the cardiac cycle will be dominated totally by the left ventricle. So the only visible vector here is the vector generated by the left ventricle. And that vector is directed to the left. And this travels away from V1, which will display a large negative wave defined as an S wave. And this wave will be large and sharp because the electrical vector is strong, and fast because the left ventricular free wall is large and activation of it is fast. In lead V5, the same vector will yield a large R wave. So again, the S wave in V1 and the R wave in V5 are also generated by the same electrical vector, which is viewed from two different angles. Finally, the activation of the basal parts of the left ventricle will only be detected in its lateral portions, and that vector will be directed to the back. This vector is not detected by V1, but it is often detected in V5, and therefore it travels away from V5, which yields a negative wave, and this wave is defined as an S wave. So this is the relationship between the electrodes, the vectors, and the ECG waveforms. And if you look at this image down here, you can see that the ECG leads, which are positioned between V1 and V5, they will actually show waveforms which are something in between V1 and V5 in sort of a progressive pattern from V1 to V5. And that is simply explained by the fact that these vectors, V2, V3, V4, they will view the same electrical currents from a different angle. And therefore they will show this progression from the pattern in V1 to the pattern in V5. Now lead V6 typically shows the same as V5, but the amplitudes tend to be somewhat smaller. So now only remains the T wave. And you may recall that we have already discussed the T wave in the previous lecture, so I suggest that you go back to that lecture. But if you are too lazy to do that, that's okay. We'll do a quick rehearsal. This is how the normal T wave should appear. The T wave should have the same direction as the main direction of the QRS complex. So let's look at this QRS complex. We see a small negative Q, a small negative S, but a very large and positive R. So it is mainly positive, or predominantly positive. So the QRS complex is positive. In this scenario, the T wave should also be positive. And some of you may wonder, shouldn't the flow of ions during repolarization, that is the T wave, be opposite to the flow of ions during depolarization? And that is actually true, because those ions which have moved during depolarization, they must move back to their original place during repolarization. So the flow of ions during repolarization must be opposite to the flow of ions during depolarization. So it would be logical if the QRS and the T had opposite direction, since the flow of ions is opposite. Well, the answer is both yes and no. The flow of ions is opposite during D and repolarization, but the T wave is still positive. And this requires an explanation. Consider this image. This is the left ventricle, the interventricular septum, and the left ventricular free wall. This is the endocardial muscle layer, where the Purkinje fibers run. The Purkinje fibers will deliver the electrical impulse to the contractile cells in the endocardial muscle layer. The activation will therefore start in the endocardium, and the activation will then spread towards the epicardium. So this means that depolarization will be directed from the endocardium to the epicardium. Now take a look at this image. This is the appearance of the action potential in the endocardial cell and the epicardial cell. As you can see, the appearance of the action potential is similar, but not the timing. The action potential will start later in the epicardium, which is simply because the epicardial muscle layers will obtain the electrical impulse later than the endocardial cells. But you can also see that the action potential is shorter in the epicardium, so the repolarization will start earlier in the epicardium. So repolarization will actually start in the epicardium, and it will be directed towards the endocardium. So to sum up, this image shows the direction of the electrical vectors during D and repolarization. You can see that depolarization is directed from the endocardium to the epicardium, whereas repolarization is directed from the epicardium to the endocardium. So the electrical vector is oppositely directed during D and repolarization. Now remember that the flow of ions is also oppositely directed during D and repolarization. And this means that both the flow of ions and the direction of the vector will be oppositely directed. And these two opposites will actually take out each other so that there will be no net effect of these phenomenon. So the direction of the T wave on the ECG should follow the direction of the QRS complex. And that ends this lesson. I hope you've learned a lot, and I dare to say that we have now covered the most important concepts of clinical electrocardiology with regards to the physiological principles. In the next course, we'll take a look at the ECG waves in detail, their origin, and how to interpret the waveforms.